Hello, I am Dr. Shekhar Ambardekar, interventional cardiologist. Over last several years, management of heart failure has advanced a lot. Starting from the days of digitalis and diuretics, we have come a long way with a big armamentarium of drugs, devices and even surgery. And the outcome of cardiac failure patients have improved a lot. But does it end there? What is the role of cardiac rehabilitation? And to discuss that with me, I have here Dr. Aashish Contractor, who heads the Department of Cardiac Rehabilitation in HN Reliance Foundation Hospital, and Dr. Tilak Suvarna from Asian Heart Institute, who looks after the patients of cardiac rehabilitation at that institute. So, Tilak, basically, how important is cardiac rehabilitation in cases of cardiac failure, and what exactly is meant by rehabilitation in cardiac failure patients?
Right. So as you rightly said, the survival with heart failure has improved considerably. However, the prognosis still remains poor. 30 to 40% of patients of heart failure die in the first year after diagnosis. And also importantly, 25% of patients who get discharged after an episode of acute heart failure, they get re-hospitalized in the first 1 year, which means 1 out of every 4 patients who get discharged, they come back with decompensated heart failure in the first 1 month. And why does this happen? The first thing happens because I think as cardiologists, we are treating our acute heart failure patients much better. However, the same thing cannot be said about the treatment of heart failure once the patients go home, and that's where I think we are lacking. And this is where cardiac rehabilitation has an important role to play. And several meta-analyses have shown that cardiac rehab not only improves the functional capacity, the exercise duration, the heart health related quality of life, but it also reduces hospitalizations and reduces mortality too. And therefore, cardiac rehab is increasingly becoming an integral part of the comprehensive care of heart failure. So that is the importance of cardiac rehab. Okay.
But what is cardiac rehabilitation? I mean, is it only some exercise, or correct, is there something more to it?
Correct. So here let me use an analogy of say a criminal who is in a prison and who gets released from the prison. And now these criminals, once they are released from the prison, they need to be rehabilitated. Otherwise, they will come back to the prison in very quick time. Same is the case of heart failure patients. They need to be rehabilitated once they are discharged from the hospital. Otherwise, they will get re-hospitalized very soon. And this is where, as I said, cardiac rehab plays an important role. Now, cardiac rehab, besides exercise training, because if it was just about exercise training, then it would have been very simple. Send all our patients to the gym for exercise and they should be fine. But no, it's not like that. Besides exercise training, it also incorporates a comprehensive disease-related self-care counseling, which means involving or enabling the patient to take care of his own disease, to be more aware of his own disease. Because studies have shown that programs which involve self-care approach, they result in fewer hospitalizations and reduced mortality. And therefore, and also patients who get re-hospitalized, it has been seen that they are lacking in self-care, which means lack of adherence to medications, lack of adherence to dietary regimen, or their inability to understand or to recognize the symptoms of decompensation. So lack of awareness of their own disease process has resulted in this increased mortality or poor prognosis. And therefore, self-care plays an important role in cardiac rehab. And therefore, cardiac rehab, in a sense, I think I would say it's a medical supervised program, which incorporates exercise training, as well as patient education. That's important. When I say patient education, it means education about the patients, about the risk factors, education about the diet, as well as counseling, psychosocial counseling of not just the patient, but also the relative. Right. So the goal of cardiac rehab is to stabilize, is to reduce the complications of the heart failure, and in some cases even reverse the progression of heart failure.
Okay. And then when does it start in a case of heart failure? I mean, do we wait for some period? Do we send them home and then we call back? Or does it start right from the time of admission?
Correct. So I think the process of cardiac rehab starts right when the patient is in the hospital. That's the time when he is going to be very prone to listen to what you say. So it starts in the hospital and maybe just before the discharge. In fact, the discharge process has to be more extensive. In fact, it would be very useful to have a discharge checklist, and a lot of hospitals do have a discharge checklist wherein you tick off the boxes. So the medications that you give, make sure that the medicines that you are given are GDMT, guideline directed medical treatment. Make sure that you have the beta blockers, the ACE inhibitors, and other drugs which have been shown to reduce mortality there on the discharge paper, as well as educating the patient about diet, about exercise, as well as about the drugs that he is taking, how to take those drugs, and to recognize the symptoms of decompensation, and then whether he can by himself adjust the dose of the medicine. So also monitor his clinical status when he goes home. So the cardiac rehab process starts right from the discharge process.
Okay. And who are the people involved in giving this rehabilitative treatment to the individual with heart failure?
It starts with the cardiologist, but the problem is the cardiologist never ever has the time to take care of this aspect, and therefore there are other people who come in, cardiac rehab specialists like Aashish, or then once the patient goes home, the primary care physician also has to play an important role. The problem is the primary care physician often is not on the same page as you are, so you often write a treatment at the time of discharge, and after 1 month when he comes for follow-up, you see some of the medicines have been omitted. So it's very important to involve the primary care physician also in the care, then the nurse, then the physiotherapist, the dietitian or nutritionist, and a psychologist. So these are all who form part of the cardiac rehab program. Here, I think in India, the primary care physician would be playing the role of so many others. Like he could play the role of a nurse, of a dietitian, as well as the psychologist.
Okay, and as you rightly said, giving the complete medical treatment as required by a particular individual is part of really rehabilitation, isn't it?
Yes.
That means if a particular patient requires some intervention,
correct,
that intervention also should be done before we think of rehabilitating the patient back.
Correct. The components of cardiac rehab is not only just the medical management, the optimal medical management, but also optimal device management. So a patient requiring a CRT or an AICD should undergo that treatment. Yes.
Okay, but certainly exercise becomes a very important part.
Important, absolutely.
And then, Aashish, what is exactly the exercise given to such patients? I mean, is there a particular protocol that is followed, or it has to be individualized? When does it start? When does the exercise start?
True. So, I mean, before I start, firstly, let me say it's a great pleasure to be amongst the company of two of my favorite cardiologists. So, thank you to the organizers for having me here and putting me in such august company, and I mean that with all seriousness. So let's firstly define what is exercise, because when we use the word exercise, especially doctors, not just the patients, but the doctors, the patients' families, they get very scared, if I might use the word. Oh my God, my patient was in hospital, they survived a heart attack a few years back, this time they came in with breathlessness, they survived this, and now you're saying go out and exercise. So even literally getting up from this chair and walking to the door in this room is a form of exercise, right? Any body movement, any physical movement done in a sort of purposeful manner could be called exercise. So basic exercise, which could be just getting out of the bed and sitting in a chair, can literally be started, like Tilak said, right from the hospital, the moment the person's a bit stable. But when we are talking about a more structured exercise program, if you look at two large components of exercise, right? If you consider one is what we call an aerobic, or typically we call it a cardiovascular exercise, and the other, which we call strength training, or a better word to use is resistance training. So if you look at the aerobic component, the simplest is walking. I have a very simple formula. Start with walking between 3 and 5 minutes, 2 or 3 times a day, and every week ask the patient to increase it just by 5 minutes till they reach about 20 to 30 minutes comfortably, and they can then stick to that. Now some people may not be able to reach 30 minutes at a stretch. Let them do 10 or 15 in the morning and 10 or 15 in the evening. So this is the easiest prescription, which does not involve heart rate and monitoring and all of those things, right? So just a simple take-home message. Resistance training or strength training, people again get scared that, they think of, bodybuilders or, Bollywood or Hollywood actors, and that's not it. If you lift a simple bottle of water and move it up and down 10 times in your arm, that's like doing a 1 kilogram dumbbell. It's like lifting a 1 kilo weight. And having strength, or having, preserving your strength is important for activities of daily living, as we call functional. So strength training must be incorporated a few weeks after the cardiovascular training starts.
Okay. And before you start this exercise program,
Yes.
do you see that a few tests are done, maybe blood test, maybe echocardiography or whatever,
Right.
and to decide what exercise is going to be
Yes.
designed for which patient?
Correct. So I think the when we look at any testing, now the buzzword in all of medicine is outcome measurement, and it should be that. A simple way is we can look at some test of physical function, and the easiest is a 6-minute walk test. Okay, as the name implies, the person needs to walk for 6 minutes. Ideally, you should have a nice measured corridor. Look at their resting parameters. Let them walk back and forth between the two cones that you put for 6 minutes, and you can tell them that if they need to stop in between, they can stop. At the end of it, again, check their parameters. Let's see how their heart rate has responded. If you are in a tertiary care center and you have the advantage of having their ECG monitored by telemetry, great, you can have that. If you can have their oxygen saturation measured, that's even better. And the 6-minute walk test is a very simple physical test. I also recommend that it should be nice to do some kind of quality of life questionnaire. Now, there are several quality of life questionnaires which are even specific to heart failure, but there's a living with heart failure or quality of life heart failure. There is the SfHFTCON, which is a very generic test. And there's also a test for psychosocial, as Dr. Tilak mentioned, we should be even screening them psychosocially, depression. There is a PHQ-2 questionnaire which WHO sort of suggests, where you just ask 2 questions: have you been feeling depressed, etc. And if the person says yes, then you refer them for further. So I would go for a 6-minute walk test, I would go for a quality of life simple questionnaire and a psychosocial questionnaire before they start.
Okay. And when we are following up these patients,
Yeah.
how do we assess that they are really being benefited by our program?
Okay. So that's a good question. Again, we get to this whole outcome thing. Obviously, if you're doing it in a study or a research manner, we'll track them for a long period of time. We will look at things like repeat hospitalizations, etc. But one of the best rule of thumbs that I go by is, again, their functional status. If in heart failure patients also, just to take a step back, you got the people who are functionally fairly normal. They may be even 30 or 35% ejection fraction, but they're living a normal life. And there are others who get tired by just having a bath or making their breakfast. So those people, I would look at their functional status to see if it's improving. As Tilak said, education is hugely important. We would counsel them on food, controlling the sodium in the diet, controlling their fluid intake if they are a reduced ejection fraction. We would guide them to do simple things like checking their weight regularly, maybe on a daily basis. And if you notice a fluctuation in weight, then they may be retaining fluid. If that's accompanied by breathlessness, then we would maybe up some of the diuretic medications, so you prevent hospitalizations. So we would on a regular basis be checking all of these, doing 6-minute walk tests every month, for example. This is what I would do.
Okay, right. Now, see, these days, more often our management is guided by some guidelines,
Correct.
some studies, etc.
Correct.
So in cardiac rehabilitation in heart failure patients,
Correct.
Are there studies, are there guidelines?
So there are studies and guidelines. There are now 3 Cochrane reviews which have been done over the last decade. The American Heart Association, the American College of Cardiology, the European Society of Cardiology, all of it pretty much puts cardiac rehab as what's called a class 1 recommendation, and most of it with level of evidence A. In simple language, it should be done. As Tilak mentioned, there is great data on quality of life. There is data on reduced hospitalization. There is data on functional improvement. Data on mortality has been a little mixed because some of the studies haven't been done with quite as much as rigor as we would like them to be, but certainly in some of these other areas there is irrefutable evidence.
Okay, like very often I have seen patients coming, maybe heart failure patients treated by medical treatment, surgical treatment, whatever.
Yeah.
After that they have followed rehabilitation program,
Yeah.
and later on when I am clinically following them up,
Yeah.
I see that really they are benefited.
Correct.
However, are there control studies? I mean, people who have not undergone this program and people who have undergone
So
this program?
there are. There's one in the US called an HF action trial. There was one I'm presenting on where they studied them, followed them up for 10 years. It was an American-Italian collaboration, and they had exercise session twice a week for 10 years, and they had 2 groups, and they're roughly about 200 patients in each of them, and they found that those who had followed up on the exercise regime had their VO2 max, which is a indicator of their cardiorespiratory fitness, preserved, their quality of life was better, and they had fewer hospitalizations. In fact, strangely, today there are studies looking at even high intensity exercise, so making them push themselves, something which we would consider taboo even maybe a decade ago. To be honest, in my practice and in the Indian setting, we are not using that because, like I said, exercise itself is a big cultural barrier to overcome in such patients. So we're not pushing them into high intensity, but studies are there showing that high intensity is safe and beneficial.
Okay. Similarly, are there untoward effects of exercise program or rehabilitation program? Are there some risks in putting the patient into this program? That will be a fear.
Correct.
In our minds whenever we are
Correct.
advising, because
Yes,
all patients are not the same.
Yes. So, to be honest, there is obviously risk in almost everything we do, and as clinicians we always look at the risk versus benefit ratio, and some of the things to watch out for are within this subset. There will be those who, within the chronic heart failure subset, there will be some who get into what we call the acute phase or a decompensated phase. We need to look out for that. So we need to proactively look out for signs of water retention, signs of breathlessness, if the person suddenly has put on weight. So this is the more, if I may use the phrase, delicate population than the standard coronary artery disease population. And we do need to be a little bit more proactive, and we need to be watchful that we don't, if I may say so, push them beyond what's that sweet spot. Doing nothing is not beneficial, and if you push them too hard, some of them may decompensate. So definitely we need to be watchful.
Okay, because I have seen patients treated by you who later on go to marathons.
Yes.
Isn't it?
Yes.
So, and of course you must be really checking that they are really the patients who can safely do that also.
Yeah, so we used to do that. I mean, Tilak's patients, your patients, they've all, we typically all, the secret is to take them up in a very gradual manner. And again, the take home message for everybody is not that all cardiac patients need to or should run marathons. Let's be very clear about that. It's just a question of that they can do it. It's not that they need to be limited. If someone wants to do it, they certainly can. So they shouldn't limit themselves. And I think a dialogue with the cardiologist is very important. I think today in medicine, what is most important is that cross multiplication team that's important. And I know that with Dr. Tilak and with yourself as well, we've had so many dialogues about specific patients. This person's pressure is not looking good. Can we address it? So that timely intervention. I think the greatest advantage of cardiac rehab is not all the scientific stuff that we may do, but it's just the fact that the patient is closely monitored, and therefore you're able to pick up something quickly rather than letting it get bad. And if you have a good conversation with their interventional cardiologist, with their surgeon, I think it benefits the patient greatly. I don't know what Tilak feels about that.
Yeah, and because of such program, like some patients' apprehension, does management become a little more expensive? Why I'm asking you this is, only yesterday in a hospital, I saw a relative of a patient arguing with physiotherapists who are looking after rehabilitation that why are you coming and putting your bills, because just for taking 4 breaths you are charging us something, so we can breathe on our own. Why do we do that?
So finance always is an issue in medicine, but to be honest, doing a good program is more about a mindset of the whole team rather than just expensive intervention. If you are in a resource scarce setting, it can be done with almost no equipment. As long as there's reasonable monitoring going on, you can use simple heart rate monitors which cost 4,000 and 5,000 rupees. It's just close supervision that's important, and the intent is important. So you can do it without space, without equipment, as long as you got good people and you've got the right protocols in place. I think you can easily do it.
And I think this question becomes important only because some patients, they spend lakhs of rupees on interventions and devices and medicines, but when it comes to exercise program, for that if they have to spend money, then they start wondering.
Correct. So that's hopefully where programs like this will create the education and awareness to prevent.
And I think it's more of awareness among the treating physicians and patients alike. Now lastly, I'll just ask both of you to give some take-home message for the physicians, cardiologists and all patients.
So I think the message would be for all cardiologists to to acknowledge the fact that cardiac rehab plays a very important role in the treatment of cardiac failure, and to go all out and make all efforts to impart cardiac rehab in your patient of heart failure. And if you're not able to do it, you should send him to a place which has a good cardiac rehab program. I think this is what we owe our patients of heart failure.
So I think, he's summed that up beautifully. I want to add one message. They say there's a phrase, do not judge a book by its cover. So I would say that do not judge a heart failure patient by their ejection fraction.
Very true.
So, as we've seen that in the past, and all of us have been earlier guilty of it, that moment somebody's ejection fraction is low, below 35 or 30 or even 25, they suddenly, we tend to have a very hands-off approach, and it almost seems to be just sit at home, do nothing, because that's an easier thing for us and not take responsibility. But today there's enough studies shown that there's no direct correlation with ejection fraction and functional capacity. Yes, there's no question that 100 people with normal EF will be better than 100 people with low EF, but that does not mean that if the person has a low ejection fraction, they cannot or should not do anything. Today we know there's heart failure with preserved ejection fraction and there's heart failure with reduced ejection fraction. So do not, if I may use the phrase, discriminate with people with reduced ejection fraction. Yes, one might proceed a little more gingerly with them, a little more carefully, but don't deny them the benefits. And to reiterate again what Tilak said and what you mentioned is that do not view this as a purely exercise program. View it as an extension of your practice, an extension of your practice with secondary prevention, where you have a comprehensive team approach. The cardiologist can be the captain of the team. There's a rehab physician. There is a dietitian. There's a psychologist. There's an exercise person. And in our country, where yoga is so much part of our culture, if I might say so, you can have a yoga person involved, which again helps from the mental aspect, the meditation, breathing, and a good comprehensive program will give your patient the best quality of life possible, and hopefully that's what we are all here for after all.
That's the main aim. So I take this opportunity to thank both Dr. Aashish Contractor and Dr. Tilak Suvarna. We had a fantastic discussion. Thank you.
Thank you. Thanks everyone.